Tēnā koutou, tēnā koutou, tēnā koutou katoa. Ko Louise Signal Takawingawa. I'm a professor at Otago University here in Wellington, and it is a great pleasure to join with Jane Bryson here at Victoria University to welcome you to this joint symposium between the University of Otago Wellington and Victoria University School of Business and Government. It's an absolute joy for me to have with us today Professor Ilona Kickbusch. She's somebody whose work I've admired over more decades than I'm really prepared to admit, Ilona, to be honest. She is a global health leader, an advisor to governments, an academic, of course, and an advisor too to government organisations such as the World Health Organization, for whom she worked in a past life. She was a key instigator of the Ottawa Charter, an approach to health and well-being that has really been adopted globally. I've been at global conferences and there's representatives from practically every country in the world who are speaking of this fantastic idea that we need to understand people's needs and the context in which they live their lives from a personal point of view, a community point of view, and a political point of view, and particularly in this current global world from a global point of view. So it is a great pleasure to have Ilona here to speak to you today about her work and thoughts on health and all policies, moving the needle towards a wellbeing society. So I hand over to you, Ilona. Thank you very much.
Well, thanks very much, Louise. Thank you all for having me here. My only complaint is the bad weather. But then I got news from home, Switzerland, that the weather wasn't much better either. So even though it's summer there, so I might as well live with it. So I'll just share some of the thinking that I'm involved in a number of venues, including also the World Health Organization, but also it's very exciting for me 2 weeks ago to be in Iceland at the Economy of Wellbeing Conference, which also brought together the countries, including New Zealand, who are part of the Wellbeing Alliance, and many of the discussions that were going on there. And I think this debate is actually very much influencing, not necessarily changing, but influence the way we speak about health in all policies. So I'm trying to press this and nothing happens.
Use the scroll on the mouse.
Oh, I hate that. How? Sorry about this. It just froze. Again. Okay, let me see. I can talk without PowerPoint, but gently scroll it down, I'm sure. So, all right. So I've tried to define a number of pathways how one can have that conversation. And my suggestion is, pathway one is obviously, as one should usually do, is to define the goal. And when through the Ottawa Charter and the first action area, healthy public policy, which then got turned into the terminology of health in all policies, actually through Finland, and was then adopted because it was more easy, I'm told, to translate health in all policies than it is to translate healthy public policy. And I do think there's a slight difference, but that's not the subject today. There, of course, has been over the years this criticism, but also I think people who've been doing health and all policies have experienced it, that other sectors, other people ask, what is this? Why should we be doing health? And what is the use for us? And therefore, people have been trying to sort of say, how can we bring across what we're actually trying to do, and that is to generate action on the determinants of health jointly in cooperation. And of course, those of you that know the WHO constitution and the definition of health will know that it actually speaks of health and well-being, physical, mental, and social health and well-being. But partly it was the WHO itself and health people that forgot the well-being side of it. So in a way, WHO is also rediscovering its own origins. And part of that happened in 2021. You might know that following the Otago Charter, there's been at regular intervals international conferences on health promotion. And the 10th such conference took place in 2021. It was an all virtual conference. You will know why. And there, the agenda of health promotion was sort of moved forward, was expressed as that the goal is, and I quote it here, sustainable well-being societies committed to achieving equitable health now and for future generations without breaching ecological limits. And so you can already see how a lot of the thinking that has emerged over the last 20 years, what are actually priorities as one moves forward to define or have, in quotes, health in all policies, that the fact of the ecological dimension, even stronger focus on the equity dimension, and the focus on the future, not just on those who are concerned now, has been formulated there. The conference, interestingly enough, like the Ottawa Charter, encouraged action in 5 areas. And here you see in area 2, again, a slight redefinition of health in all policies. It says create a public policy, so it's going back to healthy public policies. Create a healthy public policy for the common good. Actually trying to say, this is not just about health, but public policies that create a well-being. There's an explicit link into the economy, and I'll come back to that. There is, of course, the specific reference to universal health coverage, the explicit reference to values and the planet, also linked, of course, to the Sustainable Development Goals, something that we didn't have when we wrote the Ottawa Charter. And then something very dear to my heart, that this conference and this statement on the Wellbeing Society also already includes to address the digital transformation and to counteract harm and disempowerment and to strengthen the benefits of it. And it's one of the first larger major WHO documents that actually takes on this issue of digital determinants as part of well-being. And this is a message that we're working on, and maybe we'll talk more about that later. This is obviously linked to another discussion, but the two debates are becoming more and more integrated, and that is what's being called the well-being economy, or the economics of well-being, the economy of well-being. Actually, being at that conference in Iceland, people sort of use the terms interchangeably. And the interesting thing, of course, is here the starting point is an economy designed to serve people and planet, not the other way around. And otherwise, I think the language is very, very similar. And in a way, it's a question, sometimes even a question of who you're talking to, if your starting point should be the economy or if your starting point should be the society. And that's just the reality of politics, I think. Now nothing is happening again. I apologize. Okay, here we go. And then there's been another discussion which also links into these two conceptualizations of, a modernized version of health and all policies. And that's the work of the WHO Council on the Economics of Health for All, which I was honored also to be a member of, which has also produced a lot of materials, where at this year's World Health Assembly, a resolution was also tabled, supported or initiated, I should say, by Finland, also because of Finland's leadership in relation to the well-being economy. And the very short version of that is build economies that value and promote health for all in all its dimensions. So what we can see at the international level, in the discussions around health promotion, but also in relation to many of the determinants that we are discussing now, of course, the social determinants, the commercial determinants, increasingly digital determinants and climate determinants, that one is trying to sort of pull that together in a kind of consensus language where one can move forward and work in new ways. And of course, there's a major historical difference also here, because if you think 1986 Ottawa Charter, in towards the end of the 1990s, there was on the one hand, the Social Determinants Report by Michael Monmouth, but on the other hand, the Macroeconomic Commission on Health by Jeffrey Sachs. And the title of that report was investing in health for a better economy, or something like that. So you can see the differences that are starting to emerge, to say, either you say invest in health and you'll have a better economy, or you say you should have an economy that actually works to produce health. And there's lots of stories around that one could tell, but I'll get on with my presentation. So, of course, this isn't just built on nice thinking and playing around with words. It's also very much built on data, and very much built in particularly on data that have been developed, collected, shared by the OECD, that's been working on well-being for quite some time, has an extraordinary data resource on well-being. Some of you might be familiar with it. And you can just see here, without any of the details, how that work has grown, how countries are starting to develop national frameworks or plans, or at least trying to collect data according to such a well-being concept. And do take the time to go on the OECD website. You can click on your own country. You can see all kinds of things. It's an incredibly important resource. And I think particularly for health and health promotion people, being able to argue with very reliable data from an organization that is committed to economic development is a very, very important point. So it's not always, our health data, our epidemiology, etc., but it's really saying, look here is the leading organization globally for developed economies that is saying, there's real value in doing this kind of thing. And you can see that a number of the countries that are in the Wellbeing Alliance are also part of this. I hate this. So one example here, just because I've also just traveled there, I know there's work on this well-being budget, of course, also here in New Zealand, that of course also got, as in many other countries, had some problems during COVID, etc. There's always questions how much such frameworks continue through different governments, etc. And this here is the example from Australia. You know your own framework here in New Zealand. And you can see again that many of the elements that are important to us in what we would call a health in all policies discussion are clearly reflected here in this framework. And so you can see, what's the healthy in measuring what matters is a society that people feel well already, that it's in there. And, there's physical and mental health, of course, there is health services, and there's health information. So these are, very useful tools if one is going into a discussion on health in all policies or well-being in so many different ways. And of course, there is the measure of, how do we understand a prosperous society that also enables us to have many of these other things. And the important thing, by the way, particularly if we look back at COVID, where there's been quite a narrow understanding of health security, is that here the secure means a society where people live peacefully, feel safe, and then have financial security and access to housing, which is basically social determinants of health in our view. So you see once a society, in whatever way, as a general framework, as an approach to investment, as a reporting mechanism or whatever, you can see that actually for health people, there are so many entry points in many of these kind of approaches that I sometimes feel one should use much more proactively. And in some of these cases, health people have been involved, but interestingly not in all of them, and health still appears. So I think that's quite interesting. So pathway 2 is, of course, I've already alluded to it, that as we move forward to understand and prioritize the joint challenges. So that's also, some of you know that I was very active in building the health and all policies approach in South Australia. That was really the starting point, co-production. It's not for the health people to go in and say, this is important to us, and therefore, you should jolly well be helping us, but actually to say, what are our joint challenges? And I think the developments in the last 10, 20 years have, of course, shown us how dependent we are on other systems to reach our health goals, but also the other way around, that other systems are starting to realize that if we don't reach our health goals, they are also going to run out of money, because the health system is going to catch even more of those resources, which is leading to a lot of conflicts in many societies, because the way our health is getting worse and worse, of course, also means more and more costs. So it's been interesting that even the Director General of the WHO has raised this nearly in the same words as the Ottawa Charter, saying we must realize that health does not start in hospitals or clinics, but in homes, schools, streets, market, workplaces, and our environment, the air people breathe, the food they eat, the conditions in which they live and work. Very nicely alluded without direct quotation. So, and it's always nice, to have the big boss, to be able to quote the big boss. And he does come back to that very regularly. And those of you that know WHO, this is the first time, starting with the General Program of Work number 13 and continued in the General Program of Work that was just adopted, that promoting health is actually one of the 3 priorities of the WHO, something we've never been able to achieve before. And the member states have agreed to that. That is, of course, critical, but it needs leadership at the top to also propose something like that. And he is very committed to that. I've alluded to the health and all policies approaches in South Australia. You can't read this very well, and most of you will know this graph, of course, the links with the overall governance, the outcomes. But what we found at that time, one of the most useful things is what we call the health lens analyses, that we actually came together with other sectors to do such a health lens analysis and say, where does health contribute to what you are trying to achieve, and where can you contribute to our goals. And I think what's really important at this point in time is to actually say, if we are discussing health in all policies and a well-being society, from the health contributions and our priority concerns, what perhaps are issues that are of particular importance. Of course, there is no way to avoid the climate agenda. And, everyone talks about polycrises, but I actually sort of think we have, a well-being polycrisis, because so many different areas are contributing to people's not well-being. And I think at this stage and I'm starting now really from well-being societies, where society is experiencing a climate crisis, where society is experiencing a crisis of psychological distress, and where society is experiencing an obesity crisis, we have to say, how do we contribute to reducing that? So, you can identify each of these three as a health crisis. Obviously, you can. But I think it's becoming much more important to define it as a societal crisis, and then, give the argument in terms of the well-being society, why we have to resolve it together. And again, something I must say we didn't have that much in our perspective when we developed health and all policies all those years back, is where the health system itself is the problem, or is part of the problem. We did have, if you remember, as the fifth action area of the Otago Charter, reorient health services. So we were very aware that things had to change. But over time, I think this contribution of being the problem yourself was perhaps not that present. And I think, for example, this is, of course, if you say health and all policies, where we can align with colleagues from the climate movement, from the environmental movement, is what can, would, should, could the health sector contribute to resolving the issue of climate change. So, of course, we can continuously advocate, and rightly so, that fossil fuel and this and that and the other, and it's actually a big gap in the resolution from this year's World Health Assembly on climate and health that the word fossil fuel doesn't appear. But all the same, if the health system is responsible for 5% and more of total greenhouse gas emissions, then we better get our act together. And that, of course, means credibility in terms of health in all policies. And this is the example from the UK. There are, of course, other examples. There's WHO initiatives on this, and that is one example. The other is food systems, and I think here also, of course, we work a lot on the commercial determinants of health around food systems. And all this is, of course, significantly linked to the societal problem of obesity. But in terms again of co-production, of working together, to be much more aware that 1/3 of total greenhouse gas emissions is linked to the food systems. So actually, as we develop strategies to counteract obesity, to counteract highly processed foods, all those kinds of things, to actually even explore the interface between the fossil fuel companies and those companies on the other side, is something that is important. And again, I think, brings those issues straight into our own backyard. And we need to show that at least we're aware of it and also willing to do something about it. And we might actually gain more allies and more support for some of the suggestions we have around addressing the problem of food systems and addressing obesity systems if we did that. And so, just as increasingly we need to see all these areas, as systems, a climate system, a food system, an obesity system. You actually have this wonderful graph here from New Zealand, from your work on food systems, on how, many of these things interact, and how one could take the agenda forward. And of course, the role of food environments, local food, which again is linked to fossil fuels, etc., is very important. And if we made some of those things more visible, that could also have an interesting impact. Just two more issues where the well-being, health and all policies debate has actually moved forward, and where we have to look at it more seriously. And I've consciously juxtaposed the WHO definition of health and this new, much more integrated One Health thinking that, of course, in some ways could be considered a sort of health and all policies thinking. But that would be a bit colonialist, I think. Not everything is built on our thinking, but this constant trying to weave together these 5 major areas that you have here in this sort of One Health house is, of course, an ultimate coming together co-production approach that is really, really important. And this is just the example from the work that we are doing in terms of linking to this agenda, how we promote the health of young people, the digital world, and what that can mean. Now, there's been continuing work in WHO on health and all policies. And interestingly enough, you will see here that they don't only speak of technical and operational challenges, they actually do also speak of ideological challenges. And that's quite interesting that actually this is addressed. And in many of the earlier health and all policies discussions, I would say people were really mostly on about, what doesn't work technically, what must be increased operationally. And there you can actually also see the 4 pillars of health and all policies. WHO has brought out a new framework on health and all policies that some of you might be familiar with. And it's structured around these 4 areas. The colleagues from South Australia were also involved in developing it. The governance and accountability for health in the political sector. Whereas, in the early days, 20 years ago, everyone spoke about health impact assessments, but you hardly ever hear that. I think rather than the health impact assessments, what we now get is the kind of well-being frameworks and well-being indicators that I showed you earlier from the OECD. The various types of leadership that are needed, the ways of working, the mind frame also of consensus building and co-production, of course, is very central. And what came into the discussion, particularly from our work in South Australia, was, how is health no policies positioned? Is it, just the goodwill of some health people who try to talk to somebody else in the other corridor? Or is it something that the government itself has adopted, like it was the case in South Australia, where there is a structure to do it, where there is money to actually take it forward, and also where there is recognition? Because, as all of you know, working with others costs an enormous amount of time. And therefore, what we also did is we looked at post descriptions, we looked at evaluation of staff, that it was actually accepted when you were evaluated that you spend so and so many hours every week working with others. So there's a whole lot of things that also actually follow through if you do this seriously as a government or as an organization. And you have to think it through very, very carefully. So pathway 3 is, that the narrative really has to bring across that this is a joint effort. And basically, if we're really honest, no matter what we did, also this Australian stuff, etc., the narrative was always health in all policies, and not, we're jointly trying to create a better society, which also includes health. So part of that is, of course, the way we then address the various determinants of health in such work, and I think while we say in the Ottawa Charter health is created in everyday life, and I gave you that quote of the Director General, this is a quote from the German Deputy Prime Minister, who is also the Minister of Economics, and is, well, you guessed it, from the Green Party, and who actually says, we are leaving a trail of devastation through the earth with our daily lives. So I think juxtaposing those two things and saying, what is it in our everyday lives that does need to change? And in what way do we need to approach that? And in recent discussions, everyone knows this graph who's in health and health promotion about, how all these determinants work together. But I've sort of said, and that's why I've put that sort of storm next to it, this sort of presupposes that these determinants are also nicely organized and put in place. But of course, in everyday life, they're much more like that storm over there, and in our consumerist societies, etc., they do also, that storm does create devastation just in how we live our lives. And I think we need to think a little bit more about that in health promotion, what that means. Some people are trying to do that, and they speak about system boundaries. Many of you will know the donut economy, and Kate Rayworth was also part of our council at the WHO. And it's, I think, a very helpful concept. It can also be used for determinants of health in a whole range of ways. But one of the things we've started to discuss is, what about health and health systems boundaries? And could we actually start to develop a donut that shows the tipping point when our health systems cannot cope anymore with the way our health is developing, diabetes rates, obesity rates, you name them all, impact of poverty on health, etc. So is there a tipping point? Is there a systems boundary for our health systems? And we were talking this morning, there have been cuts in all kinds of health systems. There's a dreadful development also in the UK, etc. But, even a very, very rich country like Switzerland is starting to experience the limits of its health system. And I think also in terms of health and health policies, we've got to start thinking about that. Because of course also in terms of elections and democracy and populism and all of that, this plays an incredibly important role because people want a health system. They want security in their health system. And at some stage, they don't understand anymore if they can't get an appointment with a primary healthcare physician because the system has reached its limits. And those limits are, of course, also financial. But the question is, okay, do we take it from education then? Or can we have increased taxes? Or do we tax the millionaires more? I don't know. There's lots of suggestions. But I think we need to start explaining better the health system's boundaries and that this is not a question of aging of society. It is not. It is about how we live our lives and that we do not address the commercial determinants, that we don't address the social determinants, etc. And that's the cost. So, whatever the issue is, if governments are not willing to address the social and the commercial, and I hope also the digital and environmental determinants, what they're going to get in return is at one stage a health system that can no longer be financed. And I think we haven't made that argument clearly enough yet. And I hope some people will take this up. And this is just to say, where is this critical threshold? When we have 60% obesity or 70% obesity, when we have even more diabetes 2 in children than we have now, where are those tipping points and how can we illustrate that to actually make the point? We come with these investment cases, you invest $1 in tobacco and then you get 25 back or something, but they don't really express what is going on. And anyhow, they don't tell you where the $25 should go to. So I think this is something that if we're serious about a new stage in the health and all policies debate, because you could argue in a very extreme way, if we don't resolve this, health is going to cannibalize nearly all policies, or the other way around, because other things have to be paid for, there is not enough money for an expansion of the health system to treat all these enormous new problems that I have mentioned. And so we I think need some new thinking about that. Also, in terms of policy and policymakers, it's important to have data. I already mentioned that. It's important to have comparative data to be able to show where you're doing well, where you're not doing well, where sectors differ, etc. Very frequently also, of course, it's about telling a story. And this has been an extraordinary story that has been interesting how people have reacted. This is a story that Jonathan Haidt tells in his book, The Anxious Generation. And he tells the story of what happened 2012. And 2012 was the new iPhone with the possibility to make selfies. And at least his data show that from that time on, the well-being and health of young women has decreased significantly. And so there is also things that catch the imagination of policymakers that we have to think about. And obviously, as I've said before, when we spoke about the ideological, that this is not just a technical issue, it is a social issue. And and again, people who've been working on the donut model or to some extent on the well-being economy or society have said that it is the well-being dimension, here it's called the being human dimension, that really attracts people. that we live our lives better together. And that human dimension, I believe, is quite important. And that, of course, also applies to the digital transformation in terms particularly of mental and social well-being, but we're also seeing physical impacts of, people not moving, etc., except those that, like myself, that are addicted to their step measurement. And of course, and I don't have time to talk about this, but many of you who are involved in health and health policies will, of course, also be working in a variety of ways with civil society, empowerment, etc. So just to come to the end, pathway 4 is, of course, to make all this actionable. But I really want to make this point that I could have jumped straight away into making this actionable, but I think we often underestimate those first 3 things, those first 3 pathways. And if we don't invest in that kind of analyses, I don't think we can be successful. And here, of course, there's loads of materials that introduce you to how you approach health and health policies. There's a whole group in WHO headquarters that does nothing else. There's a lot of materials also in regional offices. Please go on the web and you will see incredibly useful stuff. And there's absolutely no reason why I should spend time here going into that in great detail. WHO has developed this 4 pillars model, trying to, just came out this or last year, I think, trying to make clear how one can approach the different implementation sides of it, linked in some way to that other rainbow model, but trying to include the governance and leadership dimensions, those 4 dimensions that we spoke about earlier. And so you can follow that through. And you can also as you make something actionable, here's an example, like starting out from a set of data that do raise concern, really being able to show those data, being able, in this case, to compare those data to other health issues, and then being able to say that in terms of the existing strategies, one could actually do A, B, C, or D. So I think in public health we have a set of established strategies, starting with taxation and warnings and standard setting and whatever. So I think the really important thing is then also to show which regulatory, which information, which other type of strategies you actually want to take forward. And then, you can see, this is just again the example about youth well-being, that one doesn't need to say, this is a totally new world, we don't have any strategies how to deal with it. Actually, we do have strategies to deal with it. It's around access, about use, about campaigns, about regulation, and you've got this new initiative here about smartphones and schools. So, some very straightforward public health strategies that one should then discuss with the colleagues in the other sectors and say, we have 50 years of experience here. We don't totally need to research everything again. We have experience with these strategies, and you can see that here, for example. And We're talking right now, for example, with the colleagues from Planet Youth, who are the people who reduced the alcohol and tobacco use and drug use of young people in Iceland in, I think, around 10 years to make it the country with the lowest consumption. And so, you know, one can use those kind of experiences also for other agendas. And this is another example that, you know, the Surgeon General has suggested that social media should have a Surgeon General's warning, just like tobacco. And that, of course, scares a fair number of people. And the last point on this issue is, of course, to follow through with research. And and so one of the things we're trying to do in this specific area is to say, you know, can one have accompanying research as from the very start? There's so many public health in all policies initiatives that weren't researched, where we don't know the impact really and what made the difference. Even the successful initiatives, we don't really know what made the difference. Was it good advocacy? Was it good data? Was it just a window of opportunity? You know, what was it? And then, you know, last but not least, there are larger contextual challenges. I've already alluded to them. There are the commercial determinants of health. And so as one moves into these areas, one again needs to do a good analysis. There are the commercial determinants that we need to speak up. And there is, of course, ongoing I called it the old societal structures, the ongoing inequities in our society. So again, to come back to the larger issues, what we'd be looking for as we develop a new type of health and health policies or well-being society, we look for sustainability and resilience, we look for equity, we look for trust between people and their governments, and we look for empowerment. And therefore, you know, to end again with the well-being society, health and well-being for people and planet, for countries at all income levels. Thank you very much.